things of that nature. I had a great question this morning. What was fleckoni? It was, if I can back up to that slide. So from last time, just a quick review on the rhythm. There were 4 classes of major medications that were used, and we have class 1, 2, 3, and 4. I didn't get to put the word fleckoni under class 1. It was a very old agent, but I was informed that it's used quite often in the pediatric group. I have no personal experience using such a strong old agent for pediatrics. So fleckoni would be up there. If you ever see that, it's under class 1. Class 1 is subdivided to A, B, and C, but for your purposes, you don't really need to know all that. Just know that there are 1, 2, 3, and 4. And again, 2 and 4, we already kind of covered that under blood pressure as well. So if you ever see the OLAW, it's both a blood pressure medicine, but also a class 2 antidysrhythmic. And class 4 is your good old calcium channel blocker, so it relaxes the muscle and open up the vessels, or arteries mainly. And the class 3 is the very strong antiarrhythmic agent for AFib, but also been used in VTAC, ventricular tachycardia. So if you see this group of agents, they're just really strong, what they call narrow therapeutic. That means you have to use the right amount at the right time. And notice this tricky one, it ends with Allah. It's similar to the group above it, so it does have some beta blocking action going on there, but it's classified under class 3. So that was a great question from this morning. Any other questions in terms of cardiac, blood pressure, rhythm, lipid? We covered lipid last time, and the blood thinners. If no question, we'll move on to today's wonderful lecture. Also, one more recap from last time. Actually, it's on this side. Sorry about that. I'm jumping around slides here. So today we want to cover. GI meds. And if you remember from last time's outline, we'll cover the GI medications. We will cover the diabetic medicine. As you know, lots of people affected by diabetes. So we'll cover that, and there are a lot of details there. And then we will also cover just like one slide on renal agents, people with end-stage renal disease. There are certain things that they would use. I have one slide on that. And then we will also go into the infections, different types of infections, whether it's bacterial, fungal, or viral. Now, my apologies, I cannot believe I did that. When I sent Dr. Lee the slides, I skipped the antifungal slide, so it's up on the board. My apologies. I hope you can see, and if you would like, you can copy it down, but I'll email that to Dr. Lee as well. So my apologies when I start talking about the antifungal. I don't know how that one slide got deleted. So today we're going to cover the GI. So first of all, the recap from last week is the steroids. What happened was there was a question on different types of steroids. These are just a name. I know it's a busy slide, but if you see these names that you might be giving to your patient, just know they're steroids. That means they will prone to irritate the person that you're giving it to. It will make them a little bit more hyper, or have some patients, if they have some sort of psychiatric disease underlying, they would be probably more prone to the psychiatric effect of the steroid. They might be a little bit more agitated, things of that nature, especially those who are on prednisone. So that was the question from last time. What's prednisone, dexamethasone, things of that. You don't have to memorize that, just to know these are your steroids, and they have different potency. Potency means the 1 to 1 milligram, what type of effect you would see in a person. So let's say if you give methylprednisolone, which is a solumedrol, the injectable form, that it comes in an IV form that you might give to someone in ER or in the hospital, that they would make them, their inflammation will go away fairly quickly, and it's solumedrol. But the IM form, depomedrol, is milky, and don't ever give anything milky in a vial intravenously. Do not. So that's just something to reiterate from last time. And if you notice, these betamethasone, dexamethasone, they're very, very strong. For 0.75 milligram, it will provide the same effect for say, prednisone of 5 milligram. So just to know, there are different types, and one stronger than others. So we were talking about breathing last time, and again, just a recap, cholinergic agent that ends with pium. You see epitropium, tiotropium. The tropiums are cholinergic. And just again to remind everybody, our body have two main nervous systems. We have the central nervous system, and then if you kind of split the central nervous system in half, one side of us is ready to fight or flight. It's called the sympathetic side. The relaxing side is the parasympathetic. And the parasympathetic, there are different things going on, but one of the nerve group is called cholinergic. So on the relaxing side, when we relax, we breathe better. So there's a group of agents called cholinergic agents, the tropiums, open up the bronchi, the big airways, so people can breathe, whether they have COPD, asthma, things of that nature. They can breathe better, so that's to relax the parasympathetic side of the body. And then we have something similar to caffeine that also help us breathe better. That's why when we drink coffee this morning, we're more alert, we're ready to drive, we're taking those breaths better. It's because that's how it works, by excite the central nervous system. So we're more ready to take in that air and have more energy. It also stimulates the heart. Oftentimes we have palpitation drinking coffee, so if the patient received this group of medicine, you could see a little bit more fast heartbeat, or they might complain, oh, I feel like I'm having a chest pain. Can be the medicine, but always check it out. When in doubt, always look at your patient. To treat them clinically, not just the number. That's always the main thing. The main agent is theophylline, and the tremor and the headache kind of comes with it, and again the tachycardia we just mentioned. And then the next group of medicine, again it's just a review, is that we have the short-acting beta-2 agonist. Beta, so on the sympathetic side we have alpha and beta. The alpha were the vessels, so alpha, think vessels, and beta is your heart and lung. Beta 1 is the heart, beta 2 is the lungs. So when they say beta 2 agonist, is something that works on the lungs to open up the tiny little bronchioles. We have albuterol and salmeterol, which is Seravan. Albuterol is the one that works like right away. So if someone has an asthma attack, or if they need to exercise, you might see them carry a little inhaler with them. That is because that's what works right away. If you give them the long-acting one, it takes too long, and then their attack won't be relieved, or they cannot exercise. So that's the difference there. And we talked about that last time as well, again, because it could still affect the central nervous system. tend to be a little bit more restless or anxious. They may have palpitation, things of that nature. So that was from last time. And so this picture, I think that get to show you last time, is the one of some, not just one, some of the inhaler these days. They come out as a pill form. So just if you see this, you see the pill, just read the label, do pause. There are so many little labels, so many little barcodes to pay attention these days. Do read them. Some of them look so much similar. You don't want to accidentally give the wrong thing. So do just even pause, take that 1 quick second peek at the name. Don't give this by mouth. It will come as like a little punch pill format. Don't take it by mouth. It's not going to help them to breathe, and it's going to cause a lot of gut side effect, as you can imagine. So this particular inhaler is the Spirifa. The generic name was tiotropium, which we just talked about. The inhaler comes in a package like that, and I didn't open it, but once you open it, it looks just like an inhaler. But whether you or the respiratory therapist will need to drop that little pill form into the inhaler, it will puncture it, and then the patient can breathe in that powder. It's not the most comfortable, but it works fairly well. So just again, be careful if you see something that looks like a pill, might not be for the mouth. And if you ever see a syringe, it might not be for your IV, not for injection either. So whatever you receive in your hand, do pause, look at the label. Because some syringes are meant to give orally or other formats, so justify. The steroids, we briefly talked about that. It comes in different forms. Some are stronger than others. And adverse reaction, we also covered last time. How they do get a little bit more agitated, and oftentimes it could raise their blood sugar, and we're going to talk about that under the diabetes. So it could raise their blood sugar, so something to keep in mind. It will slow down their wound healing, is what we call catabolic. All steroids can break things down instead of building things up. So it's not the best for the body. It hurts the tendons. I don't know if I mentioned last time. It can hurt the tendons. So some older patients might complain to you that Achilles kind of sore. And if there's no obvious reason, like they didn't fall down, they didn't trip on something, or something accidentally hit them, and they're complaining of tendon pain, think of this. Think of the steroid. Okay, question on breathing agents. Just 5 minutes quick review. Now on to the GI tract agents. So when we're stressed, like when you study for your exam or you crunch for time, to do something, your body automatically reacts to it by producing more acid in the stomach. And same for those patients who have surgeries, patients who have accidents, car accidents, or some sort of trauma. The body reacts by producing more acid in the stomach area. So this group of patients are more prone to having ulcers, those who are stressed, or if they lose the lining, the protective lining, for some reason, whether they're getting older or they have another medication on board that damage the lining, they can develop ulcer. What's one group of medicine we talked about last time that can affect the GI lining? Someone say?
NSAIDs?
Yeah, the NSAIDs. So, and sometimes the patient have such ready access to these over-the-counter medicine, Motrin, Aleve, naproxen, things like that, or other herbal medicines, and they combine everything not knowing it can hurt them. Especially in older patients, they not only come in with an ulcer in the hospital setting, sometimes we see them bleeding from the inside, and that's no fun. So we want to suppress that acid by giving them something to help the GI to heal. So the first group, it's called the H2 antagonist, or H2 blocker. You heard of that name. What is the H? Is histamine. There are histamine receptors. I know I go into the receptors, but it makes sense once you get that in your stomach. GI lining, there's histamine receptors. When those little tiny receptors are activated, the stomach just pump out acid. That's just how it works. So when we block the histamine, it's called histamine 2 receptors, the stomach won't produce as much acid. Now, you say that's H2, what's H1? Histamine 1 is something that we have in the central nervous system. And what happened is H1 is what the H1 blockers, which I didn't cover in any of the slides, but H1 blockers are your Benadryl, your Claritin, your Allegra. Those are the H1 blockers. H1 is to block allergy, but some of them crosses the blood-brain barrier, and that's why when you take Benadryl, people are sleepy because it crosses that blood-brain barrier. So H1 is allergy and central nervous system. H2 is the gut. The main players for H2 blockers are cimetidine, renin, tagamet. This is now available over the counter. I think all of them are. Pepcid, generic name, famotidine. Ranitidine is Zantac. So you notice their name ends with tidine. Again, that's just generally, they are H2 blockers, but not all of them. Because there's one chemotherapy agent also ends with tidine, but in general terms, cimetidine, famotidine, ranitidine, they are H2 blockers. So by blocking those little H2 receptors inside the stomach called parietal cells, it reduces the gastric acid and then bring up the pH level. The weirdest part with this group of medicine, it requires acid to work. So if someone already have an ulcer, but they've been taking, let's say, Tums or something to block off the acid or neutralize the acid, this group might not work as well. So it requires acid to work. Side effect, cimetidine, and we actually wish they don't provide this over the counter because tagamet crosses the blood-brain barrier. It makes people sleepy but also confused. So it's not the best thing for our older patients. They tend to be a little bit more confused and sleepy when they take cimetidine. And all of them, all three agents require renal adjustment. So when the renal function, creatinine clearance drop below 50, we have to adjust the dosage. So that's just another thing. That's not the best idea to have these agents over the counter, but they are. So that's the main challenge. So at the hospital, we have, the pharmacy adjust the medication, but you might also want to keep an eye on the serum creatinine for this. And all three of them can cause thrombocytopenia. You recall what thrombocytopenia is, I assume. So it drops the platelet. All three of them can. So if you have a patient who's been healed from GI bleeding and they don't have other known source of bleeding and their platelets start to drop, you'll be like, what's going on? Well, this might be one of the reasons. There are some other reasons that's happening clinically, but all of the H2 blockers can drop people's platelet. And then drug-drug interactions. It can interact with warfarin and also phenytoin. Do you recall what phenytoin was from last time? Yeah, for seizures. So what happened is, you remember I mentioned the liver is being your detox center. So there are little tiny enzymes like the menin working really hard in there. But the phenytoin, it induces the menin. So they turning from yellow to purple, go crazy. It becomes a lot more of the liver enzyme. And when there are a lot of liver enzyme going on, it clears the cimetidine mainly faster, so then it won't work as well as it should. So that's just the drug-drug interaction there. And an acid. So I mentioned the Tums. What are some other an acid that you might come across? What other some of others an acid? Prilosec, but that's not an acid actually, which is the next slide. You're ahead of me. What's some other an acid you might be giving other than Tums? Have you come across that? You purchase it, use it yourself? Pepto-bismol, yes, but it's a bismuth, and I'll cover that later on. It works a little differently. Milk of magnesia or Maalox. Yeah, so Maalox, Mylanta. Milk of magnesia is more for constipation. But Maalox, Mylanta, things of that nature, or the generic equivalent, would interact with this group. As I mentioned, this entire group require acid to function properly. So without the acid, once the acid is already neutralized, it doesn't work as well. So ideally, this group of medicine should be taken before the antacid, because otherwise it's just we're pumping medicine in without the full effect. So that's this group. Question?
So is one of the side effects for the H2 blockers gynecomastia?
You're thinking of Tegretol, I believe, or aldosterone. You're thinking of the aldosterone group. Last time I didn't quite get to that. Spironolactone does that.
No, I had read that ranitidine did.
It might be a small fraction or smaller than.
So it's not very common.
It could be listed. So what happened is, in terms of side effect, it's grouped under 10% or greater than 10% of people having it, 1 to 10% or less than 1%. So I believe that might fall under 1% or less, because that doesn't come to mind as readily. But thank you for bringing up that point. What I didn't get to mention was on the Tegamet, let's see, on the Pepsid, there was one thing you just mentioned that skipped my mind. When it comes back to me, I'll mention it. Okay, on to the next slide. Okay, this group is the proton pump. So what happened is the H2 blockers, the H2 receptors, kind of like the activators for the proton pump. So in order for H2 to work, it requires acid. H2 is activated, then once that is activated, it activates the proton pump, so it pumps out all that proton. Proton is just acid, if you will. So, but proton pump in itself does not require as presence of acid to work. Therefore, this actually works fairly well because you can put it into a system anytime and it still work the way it should. That's why it's more effective than H2. It works fairly well for regurgitation diseases and ulcers, and it would heal it fairly quickly. Main players are omeprazole, pantoprazole, esomeprazole, Prilosec, Nexium, Protonix. Now, you heard of these groups, and they are available over the counter. They don't affect the kidney as much. They are all liver drug, which is wonderful for our older patient group. And for those who have active GI bleed, it's great because, again, it doesn't require that acid to be present to work. So what happened is they can take the pill and it works right away. Also, it comes in an IV form. So at Sequoia, we have Protonix that comes in an IV form. You can load up the patient with that bolus, 80 milligrams, and then give it as a drip. But sometimes they just give it as a piggyback without the drip. It depends on the severity of the GI bleed. But one thing though is weird, even though it doesn't require acid to work, if we just give the pill in itself in its plain form, it would dissolve and kind of disarm right away. So it's not stable in acid. If you see the pill Prilosec or Nexium or Protonix, it has that nice little purple capsule on it, or black, or depending on the manufacturer. But when it first came out, it was all purple. But that particular capsule, it has a protective layer, so it doesn't dissolve right away. It would go to the spot that it needs to and release the pellets. It has little pellets inside, and it would slowly dissolve and provide the medicine over that period of time. So if you ever have a patient that cannot swallow a pill, you could open it up, just don't crush the little pellets inside. But now it comes in a powder form that could be mixed into a liquid form, so that's easier. So question on this group of proton pump?
So real quick, so if you're, sorry.
No, that's okay.
So if you're swallowing the pill, you don't want it comes in a capsule, you
Right.
want to prevent the inside. So at what point do you want the interaction of acid or not?
Right, so once it gets to the stomach, that coating would slowly dissolve, and then the pellet itself is also extended release, what they call extended release. So it would squeeze out the medicine from the pill and from the pellet slowly over time. If we give the medicine in the pill form, like a tablet in itself, it's gone right away because it just kind of
So you're looking for the long-term prolonged effect.
Yeah, definitely,
Okay.
definitely. Ulcer is a hard thing to heal sometimes, especially if someone has it for a long time, or if they're actively bleeding. Thank you. If they're actively bleeding, it's harder to treat. So you really want to give the stomach rest, and that over the long period of time works better. That's another reason why it's better than the H2. H2 tend to work at like a shorter period of time, and the proton pump lasts a little longer in general.
Thank you.
Yeah. So on to an acid. This is something that we're more comfortable with or more exposure to. So they are alkaline compounds in itself, so it doesn't work on any receptor per se. It's just chemically neutralizes the acid, the gastric acid. So they are very good for certain ulcer, but doesn't really treat it. It's more for prevention, if you will. Regurgitation, it works great, and can be used for stress, ulceration, and aspiration. One thing, oftentimes before surgeries at our hospitals, or even before C-section, our hospital will give some antacid, but also the H2 blocker to prevent the excessive amount of gastric acid before surgery. Because aspiration is always also one thing that we concern of when patients have to go to OR being operated on. The last thing you need is they aspirate something and have a pneumonia. We don't want that. So the big thing is suppress the gastric acid. That's what it means by stress ulceration. Because whenever the body is put under stress of any kind, physical, physiological stress, the body will just produce acid. So we want to block that before it happens. Sometimes it can be used for differential diagnosis. Like for example, if a patient comes into ER and say, oh, I have a chest pain, but we don't know if it's just the heart or it's the lungs or is it the stomach. So sometimes the doctor might give them a little bit of Benadryl along with an antacid like Maalox in a little drink mix or other forms to see if that helps. If it doesn't, then we can eliminate the source from GI. Then of course they do other tests and blood tests and chest x-rays so forth. So antacid interacts with a number of things. You might be giving antibiotics, you might be giving other supplements or other medication. So this is the list that of medicine that you should not give antacid with. They are tetracycline, quinolones. We're going to cover that towards the end of today's lecture when we talk about the infections. Quinolone, you might know them with names like, you know them better with Cipro, Levaquin. So those are quinolones. And iron supplements will interact with antacids. They bind together and becomes useless. And certain HIV medicine. So just be sure you read your MAR, your MAR, the medication administration record. There should be a note on it. Yes.
Is it quinolone for Cipro and Levaquin?
Yes. Yeah, so quinolone is Cipro and Levaquin and things that ends with fluoxetine, but I'll cover that during infection towards the end of today. So this group of medicines should not be given with antacid. They just bind together and make them useless, so you don't want that. Or at least space it out an hour before or 2 hours after. So the main compounds, we have the aluminum compound. It's just aluminum hydroxide. It comes in many different generic names. You can purchase that over the counter. It's slow, but it produces a longer effect. The problem with aluminum, it causes constipation. So it might take care of the stomach, but it causes other issues. Magnesium, you know them as Mylanta, Maalox, so forth. They work very well, very fast, and it's very strong. Potent means strong, but it can cause diarrhea. So again, you might take care of the upset stomach, but now you have a different issue. Calcium is known as Tums, calcium carbonate, calcium citrate. Calcium comes in many different forms. But generally, it's carbonate is what we see in Tums for upset stomach. It works fairly well, fairly strong, but the rebound acid is really strong as well. So if we take Tums, after a few hours, your upset stomach might come back and come back stronger. So the key is I often recommend people that if they feel like they're, like after a big meal, after barbecue or football game or something, you ate a lot, your stomach feel like it's stuck, don't give antacid. Your stomach needs to process all the material that you just ate. So you don't want antacid, you want to digest, right? So in that particular situation, you actually want something acidic, like a little bit of vinegar or things that is a little acidic. That's why salsa or tomato might be good. So you don't need a drug. But if people come to you and say, oh, I feel like there's a heartburn, you feel that burning sensation from the acid, then antacid would be a better choice. So it depends on the situation. I wouldn't give antacid to everybody who have an upset stomach. We need to qualify what upset stomach is. Yes?
So I know some providers will advise women to take Tums for as a calcium supplement, but
Yes.
if it causes rebound, what did you call it? Acid rebound?
Right, acid
Then
rebound.
is that maybe not the best idea?
It's not the best idea, but calcium is much needed for our bones. So what happened is Tums releases it really quickly, but calcium comes in other form that it comes in an extended release form or a pill form instead of the chewable that releases everything right away. So those might be better if patients or people experience the rebound acid, but it's very, very good for our bones. So, and there's some anecdotal report also that too much calcium can cause heart rhythm issues or high blood pressure. Guess why? Take a guess. Take a guess. It causes, think of calcium as muscle contraction. So calcium, muscle contraction. So whenever you have too much of a calcium, it causes muscles to contract harder and causes the vessels to, there are little tiny muscle wall on your little tiny vessels. They contract as well. So it clamps down the pipe, pressure goes up. And then when it causes the heart to contract too hard, it can cause a rhythm issue. So to answer your question, yes, calcium Tums is great, especially if you have a low calcium level or if doctors say you're more prone to osteoporosis because your bone's small, like mine is super small. So that's a good idea, but you might need an extended release calcium so it doesn't hurt the stomach as much. Yeah, great question. Other questions? Yes?
So you were talking about extended release calcium. So do calcium citrates also act in the same way as antacid?
Yeah, so they do work very similarly, but they are not as harsh on the stomach. Calcium carbonate tends to be a little harder, but it works great for acid, and it just comes in different milligrams. What happened is citrate versus the carbonate provides different amount of elemental calcium. So it depending on your need. Does that answer your question?
Well, I was just wondering if it could also be used as an antacid.
It could. It could, but not as fast.
Okay.
Great questions. Okay, on to laxative. So it's another problem with the GI that for whatever reason, a person, your patient, been laying in bed or post-operatively, they have, what's one class of medicine that would provide all the constipation that the patient needs?
Opioids.
Yes, correct. So if, especially after major surgery, they got pumped into their body so much opioid, narcotics, their GI tract just not moving, not just from the medicine, but the fact that they're laying in bed not moving, that's not the best thing for our body, so they have constipation. And it can be from other reasons as well. Maybe their GI muscle tone is not quite there, that's another reason. But by all means, few things we could do. First one is bulk forming laxative. Is just a big word for fibers. So the first one is your fiber group. It comes with methylcellulose. It's just metamucils or other form. So it's just good old fiber. But in order for that to work, the patient must drink water. Otherwise, it will aggravate the constipation instead of relieving it, right? So if you pump fiber in, must drink water or fluid. It doesn't have to be water. It can be juice, chicken soup, something. It cannot be taken by itself. Okay. Second group is called surfactant. Surfactant, think of dropping a little bit of detergent into an oily pan. That's what a surfactant is. Surfactant is when you add that to it, it causes oil to disperse and it kind of activate the water. In this case, is to activate the water to get into the stool. So then things will move along a little bit better. The main player is called docosay or colace. You might have seen that oftentimes, the little orange capsules that the poor patients have to take. So that, again, you have to have water. You have to have some sort of water or fluid in the system to work. Next group, stimulant. Stimulant is what people abuse sometimes, that if they want to lose weight, they take this to irritate. Basically, it's just an irritation that it causes on the GI tract. It works for a time, but it can be habit forming. So if a person relies solely on a stimulant and they don't exercise, they don't eat right, they don't drink water, well, the body will get used to it and won't work. So this is only after the fiber's there, the water's there, and you also try the surfactant. Generally, that's the scope that you would go down. You would try water, try exercise, try a surfactant before you get to the stimulant. Because again, the body can get used to it, and then it won't be useful down the road. The main player is Basicodyl or Dopalex. You see Dopalex come in Correctol, I believe, and other name brands. So if you see this name in the ingredient, just think of stimulant. It stimulates things and kind of just irritate the GI tract. That's what it does. Next group is the osmotic one. Osmotic agents basically just cause the osmotic gradient to be higher in the gut than in other parts of the body. So it makes the gut more concentrated, if you will, and draws out the water from the tissue and add to the stool. So the main players we have is MOM, milk of magnesia, and it works fairly well. And then this big long word for Miralax, it's a substance, polyethylene glycol. It's almost, not quite similar to antifreeze or things in the car. So, but they work again by making the GI lumen more concentrated than the surrounding tissue, so it draws out water into the GI lumen.
So I have a quick question. If you have a patient that is using something maybe like this over time, then does it up the dehydration factor? Does
It
pull?
could.
Okay.
It could. That is a possibility. As a matter of fact, anything that gets rid of fluid or anything that gets rid of fluid from the surrounding tissue into the gut to be excreted, we are running a risk of dehydration. So assuming they will have some sort of IV going in or taking PO by mouth at that point, if they're complete NPO, they would most likely be on some sort of IV fluid. That's a great question. So another stuff that they use, Gold Lightly, mineral, so forth. Now Gold Lightly, that's used for pre-colonoscopy and some other endoscopy things because it's just a big jug of electrolyte, very, very concentrated electrolyte. So the pharmacy would give you the jug of powder, and then at the right time, you would put water into a jug, mix it really well, and have the patient drink it. From what I hear, normally they can only do like half of it, and the other half they have to do it on the potty because they just run towards the end, and it's really difficult to do. Nowadays they have something more concentrated in a smaller bottle, but have the same effect, if you will. Without Gold Lightly, it's really hard for the GI doctors to visualize the lumen clearly for the procedure. That's why they take that. And the important thing is, if you have this on your hand to give to your lovely patient, just encourage them to finish the last drop. It's really difficult. If they don't, they will have an unclean or unclear GI lumen, and then they might have to cancel the procedure because then the doctor just can't see what's going on in there. So it defeats the purpose. So you don't want them to have to do this twice. Just encourage them, gently try, and most of the time they only drink 8 ounces of it. You wouldn't be giving someone anything 4 gallons. 4 liters a gallon at a time. So most of the time the patient would drink 8 ounces. So just a glassful, a handful, every 15 minutes, and then they will take breaks in between until they finish all 4 liters. It's not a pleasant experience, but if that's what's needed to be done, just gently encourage them. Mineral oil. Mineral oil is one of the somewhat last resort, because if these don't work, so something is not going right, literally. So mineral oil is just a mechanical lubricant. It's a lubrication, basically. And oftentimes, they don't drink that stuff, but they give it per rectum, oftentimes. And as a matter of fact, they wouldn't go to mineral oil first, but they generally go to soap sud, so it's soapy water first. Yes.
Is that normally what's in a suppository, or which one of those would that fall?
So the suppository normally is glycerin. I was getting there, thank you.
Okay.
But the glycerin comes in a suppository form, and comes in a pediatric form, a grown-up form. Again, it's just a lubrication, a physical lubrication. Lactulose is the same kind of thing, but lactulose is something they can drink. Now, oftentimes you might see end-stage liver disease patient on lactulose. The reason is it gets rid of the extra ammonia from the body. Ammonia is what accumulates in the liver oftentimes when patients have end-stage alcoholic-related disease, or if they have a liver virus, if they have hepatitis, or if they have cirrhosis. Somehow, one reason or another, their livers don't work towards the end of their life. They have all these ammonia accumulated in their body, and they cannot think. It really, literally backs up into the brain, and then they have confusion. It's something called hepatic encephalopathy. So they can think they don't do well. They have to take a lot of the lactulose. So the primary purpose of lactulose is constipation, but it also works pretty well for end-stage liver patients as well. So someone already brought up the point of hydration. Very important to hydrate these patients. You can put in all the medicine, but if they're not drinking water or not having fluid in their system, it's not going to work. Yes?
I have 2 questions. First one about the lactulose.
Yes.
I have a patient on that to get the ammonia out of his body because of the liver. But he can't go anywhere in the afternoon because the diarrhea is so bad. So he's stuck in his house.
Yeah.
Is there something that they can do for that?
Not really, because that is the goal, to have them go, really. Not so much for the constipation, but it's the ammonia. When it accumulates, it's just very toxic to the body. So in terms of maybe if they do go out to have some sort of special undergarment or pad to go with them, or is the patient on a bag, on a colostomy bag or anything?
No, so he was complaining about not being able to go out because they like him to take it in the morning, but then he's stuck home all day. So he pushes it out towards like noon sometimes.
Right. Yeah. So there's no specific way to stop that because that's how it works, by making the person go. Yeah. Unfortunately.
And then my other question was the magnesium citrate. Where does that fall in?
So magnesium citrate is a magnesium, so it would be very similar to your MOM, except magnesium citrate is even stronger. It irritates. Well, it doesn't irritate, but it draws water so much faster than your milk of magnesia. It's magnesium, but the citrate form really gets the person going. So oftentimes that is one of the last resort. So the last resort is your mineral oil, your enema, the max citrate. Yeah, those are the times when they're really plucked up. And then, of course, the last step would be surgical, but we try to prevent that. Yes?
I work in a GI doctor's office, and they use the Sigma citrate for flexing, so not going up the whole way. They use that in enemas for.
Yeah, if they have an urgent situation or someone who cannot take that much by mouth for whatever reason, mechanically they can, that is something they could do. But I hear that anything else other than golightly type of oral, it doesn't clear the feel as much, as if you will. So you could do that in an urgent.
Just flexing though, not the whole way.
Yeah, not the whole way. So that's something you could do. So fun stuff with a GI. Question? Yes.
I'm scared to ask, but is there like a hierarchy of like if you're a nurse and a patient says I'm really constipated, which one would you give first?
So
like,
first is water. Make sure they drink the water. Second, prune juice, because oftentimes maybe they just need a. So again, just like any medication.
Can of worms.
Right. No, it's a great idea. What happened is, just like any disease state, your medication is probably not the first line of defense. They have to try other stuff first. So make sure they're eating something. If they don't eat something, there's nothing to go, right? So they have to have some sort of food or some substance. Water or juice, fluid of some kind. And then if that doesn't work, prune juice work fairly well. And make sure they ambulate. Oftentimes, well, if they can, that's a different story. But oftentimes, as we age, certain people, they tend to be more sedentary and just sit, and that is not good for the gut. So that's why exercise would be a good thing. It doesn't have to be strenuous exercise, It can be just a walk, take a walk, or do house chore instead of sitting. So that's something to recommend to the patient. Eat the fruit, just like what doctor would say, drink your water, eat your fruit and veggies. Then if that doesn't work, then you go down this list. The fiber, with water or some kind of fluid. Surfactant to something to draw water in to penetrate the stool. Sometimes the stool is just hard. Even though they're drinking water, they're doing everything right, the stool itself is hard because they don't have enough fiber in their diet or whatever the reason is. Okay, so allows the water to penetrate the stool. Then they could try the irritation part. It's not the best because I was told that it actually gives them cramps sometimes. I'm not sure where your patient might be, but when you work with the patient, try that list first. Try the natural processes first, food, fruit, water, fiber. Then you can go down this list, and then you could go to the milk of magnesia as well. But then the miscellaneous, also the enema. Oftentimes in a hospital setting, I've seen doctor prescribe the digital, I forgot the exact term, but basically it's the maneuver of nurses will have to maneuver the area to stimulation, thank you, to get the person going, or enema. Soap sud would be first before mineral oil, so soap sud goes first. In the past, there's something called fleet's enema, like fleet by itself. However, fleet by itself has a very high concentration of phosphate. It's like sodium phosphate, potassium phosphate. And for old patients, that's not a good idea. Phosphorus tend to stay in our body. That's why preservatives are bad, because preservatives often comes with phosphate. So we don't want all that fleet's enema. It's no longer recommended by GI procedures or GI doctors because it has so much phosphorus. So after soap sud and all that stuff that we try, then you go to mineral oil. And then the Mexitrate and so forth.
I'm just going to ask, because you hit on the sodium. So a lot of a diet high in sodium, doesn't that also bind the fecal together, and it makes it it can create harder stool and things? So
it can dry up the person. That's
okay, so
it definitely could dry up the person. So again, just like what we're always told by our parents and doctors, drink your water, eat your fruit, eat your veggies. There's a reason for that. Yeah. Great questions. Other questions? Okay. So on to the next thing. So after we took care of one end, this is the other end, throwing up. So the antiemetics. So as you know that when people get sick, they can throw up a little bit more readily. My daughter just did that Monday, Tuesday. It's not fun. So there's things to stop. Sometimes it's induced by surgery, the procedure itself, but also things that we give the patient. The body just doesn't agree with it. So let's look at some of these. The first one is called Raglan, metoclopramide. It moves things along. Oftentimes, these medicines just move things along, so it would settle. Your inside would settle, if you will. So increase the GI muscle wall tone and the motility. Make it more ready to empty it out this way instead of up this way.
Oh.
Okay, but the adverse effect, Raglan, is known to cause sedation. It crosses the blood-brain barrier, and it can cause EPS is extrapyramidal syndrome. What happens is can make them having the dyskinesia and like what people have with some of the antipsychotic medication. They have those side effects. Raglan can cause some of that type of side effect as well. Tardive dyskinesias, they might be shuffling or they just don't look right. And contraindicated for those who have obstructions, or if they're having active GI bleed, we shouldn't be just giving that. Or perforation of the GI tract, so that's not a good idea because it causes the GI muscle to work a little harder to move things down. So if they're actively bleeding or having perforation, this is not a good drug to give. Then the next thing is Zofran, which we use a lot in the hospital, at our hospital anyways. It's a serotonin inhibitor. What happened is serotonin in our system, in the GI, tend to move things along. But what happens is sometimes it's just moving things a little too fast. And so there are different receptors in the body. When our body senses there's a foreign substance, our body would want to get it back out. So, and that's where serotonin plays an effect. This blocks that effect. It's called ondansetron or Zofran. So it works by that route. But watch for QT prolongation. It also affects heart rhythm. It could. Generally, all these agents, most of the times only given. PRN is not like a standalone drug given around the clock. It shouldn't be. The underlying problem should be taken care of first. This is given during surgeries or after surgeries quite a bit because it works fairly well. And sometimes high-dose Zofran can be given to patients with chemotherapy. If you notice, it ends with citron, and ondansetron is anything that ends with citron is a serotonin inhibitor. Kitro is another one that's given to chemo patient. Its generic name is granisetron. I didn't list everything, but just to know that stuff that end with citron most of the time is an antiemetic working via the serotonin path. Then the next one is Phenergan, promethazine. It works by increasing the GI motility as well. It has anticholinergic effect. That means it blocks off. So cholinergic is what relaxing part of our body. So anticholinergic is what kind of excited. And what happens is it can make people a little bit more confused. So those who have promethazine or anything that ends with the word thazine, it's a phenothiazine basically. It works also on psychiatric people, not this medication itself, but you might have heard of chlorpromazine, things like that. It works by moving things along, but it can also cause urinary tract retention. So when the person is not as relaxed, they tend to hold things back and have blurred vision. Their pupil doesn't adjust properly. So that's what anticholinergic effect is. Similar to, say, Benadryl. Benadryl has anticholinergic effect. That means they are more confused, as I mentioned before. Also, they can potentially have urinary retention. So it's not as good for older patients. Last but not least is the benzodiazepine that we mentioned last time. It's called Ativan or lorazepam. It's good for those who have chemotherapies. It can be given before to kind of suppress the anticipation of the emesis. So, yes, question?
So back to Zofran, does that inhibit any of the other 5-HT receptors?
No, just the 5-HT3.
So it won't have any effect on anybody who has like depression issues or anything?
Right, correct. That we know of. But it does affect the heart. For some reason, this one agent, it can prolong QTC. So what happens if I give that with Tickerson?
Oh, you're not going to have a, Tickerson's trying to shorten it a little bit.
Right.
So it's going to counteract it.
It can counteract it, but can also cause further dysrhythmia. Yeah, whenever something that blocks or interrupts the nice PQRST wave, anything that interrupts it or prolongs it or shortens it can affect how the heart beats. So just something to keep an eye on. Other questions? So almost routinely at our hospital, Raglan and Pepcid are given together for patients who are having C-sections. Because, again, with any procedures, your body is more ready to to take care of that stress, so it will produce more gastric acid. And also, with surgeries, with the inhaled anesthetic, it just make people super nauseous. So before C-sections, patients are given Raglan, Pepsid, and for other procedures, they would be given Raglan, let me see, yeah, Raglan, Pepsid, that's the main player. And Zofran, Phenergan are generally given after surgery for post-op nausea, vomiting. Okay, other question. Great. So, and one more thing on the GI is diarrhea. So when we travel or when we have food poisonings, we might have uncontrolled diarrhea or just some kind of infection. Infection in itself can do that to our bodies. So the goal is to slow things down now. Just a word of caution, when our body reacts in such a way to have a diarrhea, that's a reason. Because of the germs or because of the toxin the germs produce, so the body really wants to get rid of the bad stuff. So we shouldn't suppress it too much. Only if it's excessive, we want to help the patient to feel better. We could use this. There are two main ones out there. The first one is called Lomotil. It's a combination drug. It's diphenoxylate with atropine. Diphenoxylate in itself is kind of like an opioid-like substance, an opium. Atropine is an anticholinergic. Atropine in itself, you might see that in the crash cart because it suppresses the relaxing side. So what happens when you give atropine to a patient who has low heart rate? It will increase it. So that's right. So atropine by itself, you might see that in a crash cart to raise the heart rate. As a matter of fact, it's interesting. Our sympathetic side, our exciting side, the nerve is not as strong as our relaxing side. So when we block off the relaxing side, atropine works far better than adrenaline if you want to raise heart rate. It's fairly interesting. It's just a side note. Yeah. So it works by activating the vagal nerve. So this together, it would slow down the gut. So again, when we block off the relaxing side, the gut won't work, it won't run as much, literally. Or just give good old opium, but we don't do that as much. Opium tends to be a little bit more addicting for obvious reasons. So we should not use high dose. Either one that would cause unpleasant side effects. Well, all medication have side effects, so if you give enough, the patient won't feel well. Loperamide, on the other hand, brand name Imodium, is something you can purchase over the counter, and it doesn't cross the blood-brain barrier. So for Imodium, patient won't feel as sleepy when they take it. And it's generally better, a little bit more used in patient than Lomotil. So for infectious diarrhea versus the non-infectious ones, non-specific diarrhea, generally it's self-limiting. Again, if your body is running, there's a good reason. The body is trying to get rid of junk and the toxin. So generally, if it's an infection, food poisoning or others, it would be self-limiting. It's important not to lengthen the diarrhea by giving antidiarrheal, because the body, once you stop the medicine, they will run again because they want to get rid of that junk. But if they have severe infection from Salmonella, Shigella, you heard it on the news that these food might be tainted by these bacteria. C. diff is a really bad one, and they require antibiotics. C. diff is oftentimes, if it's in a hospital setting patient, is caused by overuse of antibiotic. So what happens is if a patient, let's say they're really sick, they're septic, they've been on antibiotics, antifungals, antiviral, and we throw everything else on it, C. diff will grow. when there is too much C. difficile, which is Clostridium difficile, when there's too much of that, the colon will just expand and become inflamed. It's called pseudomembranous colitis. So when you see C. diff, it's not good for the patient. The patient's colon will look like having slushy stuff on it. It's really bad. So it cannot be treated other than with vancomycin or flagyl metronidazole, and we'll cover that in the infection portion of the lecture. But just remember, C. diff, you have, I mean, whether C. diff or not, you have to wash your hands when you deal with your patient, so patient won't be cross-contaminated. And you have to use soap, just the hand sanitizer. You know, we have hand sanitizer that we can purchase in stores. Those won't kill C. diff. So you might be thinking, oh, I put this gel on, I'm clean. It doesn't kill every bacteria, virus out there, FYI. C. diff has to be killed by only those 2 antibiotics. Yes.
Does it have to be contracted from like another patient nearby, or do your bodies just produce it?
It can be from cross-contamination from another sick patient, but unfortunately, our hands can do that too, so it can be from a provider, unfortunately. And that's why it's so important to keep everything sterile in a hospital setting. Well, even in a clinic, let's say you work in a clinic, it's the same thing. If they've been on long-term antibiotic and they complain to you, I've been running to the bathroom, I don't know why. That's just a red flag to keep C. diff in mind, that their colon is not doing well. So yes, they can contract that from another patient, but just being in a hospital setting or nursing home, it's just not the most pleasant thing to have. And yeah, again, just wash your hands, wash your hands. I'm sure you hear that 1,000 times. Wash your hands. Travel diarrhea, we briefly touched on bismuth, Pepto-Bismol. Pepto-Bismol is not an acid in itself necessarily. Bismuth subsalicylate is almost like an antibiotic, if you will, but this also have aspirin-like effect because it's a salicylate. Aspirin is an aspirin stands for acetyl salicylate. I can't say it today, I'm sorry. So that has anti-inflammatory effect, which is good if the gut is like inflamed. It's good, so that's why for travelers, diarrhea works fairly well. It's pink, but it's not an acid, or it doesn't slow down the gut, if you will. So, so that's a major difference. So, question on GI. Okay, we'll do one more slide, but it will be on kidney, and then we'll take a quick break. Renal disease, chronic or acute kidney disease. These patients are the ones that have the kidneys coming in not doing well on dialysis or hemodialysis for a variety of reasons, whether they have an acute infection that render the kidneys function, or they probably have a bad heart that they haven't taken care of, fluid backed up in the body, and then over time, those little pipes in the kidney can only take care of so much volume. So then their kidneys won't work. So the irreversible loss of renal function showing or evidence by decreased GFR, increase in serum creatinine, or blood or protein being leaking. It's called proteinuria or hematuria. They might also losing albumin. Albumin, the very tiny protein in the body, leaks readily if the kidney tubes are not working properly. So when we see this, they are staged, generally as stage 1, 2, 3, and 4. And end-stage people is mainly the ones that we see at the hospital, and that's why they come to us. So by then they already have a whole host of cardiac issues and so forth. But just want to draw your attention to the fact that their electrolytes totally out of whack. Mainly would be, again, the phosphorus we talked about. Phosphate is something that our body needs, is essential for our cells to work. If you recall all the ATP and all that inside the cell, phosphate is what builds the DNA, so we need that. Unfortunately, when we have too much, it accumulates in the kidney. Same thing with potassium. Sometimes they have too much or sometimes they have too little, depending on what's going on. Magnesium, and I forgot one more, the aluminum that we talked about can also accumulate. So things just tend to accumulate. So guess what happened when we give too much Maalox and milk of mag or substance like that to a end-stage renal person who's complaining of having upset stomach? If we give them a lot of Mylanta,
You can't process it.
yeah, they can process it, and then they will have hypermagnesemia or hyperkalemia. So we don't want that. So we're very careful in terms of giving anything that has electrolytes in it to a end-stage renal patient. Same thing with salt. What happened is also their salt balance is not the best with renal disease, so salt content will also be something to look out for. As a matter of fact, some of the medications that you might be giving, for example, antibiotics that we're going to cover, they contain a high amount of sodium in it. That's just how they put the medication together, so it's just something to keep in mind. Anything we put into our patients' body, whether by mouth, by nose, by ear, by rectum, by IV, IM, subcutaneous, you name it, even topically, we have to be very careful. So because of the imbalance, I apologize for things overlapping. It should look a little bit better on your handout. These are the phosphorus binding agent. Calcium in itself is good news for patients. So you might see your end-stage renal patients coming in with a high dose of calcium carbonate or calcium acetate, the brand name Phoslo. It literally lowers the phosphorus because it binds to it. So calcium is good for end-stage renal patients. And two more medication. One is called fosrenol, and another one called Savelomar, which is Renagel or Renvela. They are the binding agents. Literally, it's like a molecule that looks like a mesh that binds to the phosphate and just traps it, so it can be excreted. But what happened is in the renal patient, they are also, because of the kidney not functioning properly, and I didn't get to put on the slide, red blood cells are sometimes produced on top of the kidney. Other than the bone marrow, red cells are also being produced in the kidney. So what happens in these patients, they also have low red count. So you might be giving Epogen subcutaneously to these patients as well. Or they just tend to need more blood. So that's another thing that we need to keep in mind. Also, they don't produce vitamin, their bone don't work as well. Their calcium level is also kind of out of whack. But vitamin D is required for calcium to be processed in our body. That's why if you drink milk, just look at the carton of milk or the gallon of milk you have at home. It generally has vitamin D supplemented in it because our body requires vitamin D to process the calcium to build up the bone. So in this group of patients, they don't have enough vitamin D, so they will also be placed on quite a high dose of vitamin D. So, so high dose vitamin D, calcium, blood or Epogen, and phosphorus binding agent is what you would generally see in renal patients. Questions?
I have a quick, did you
Yes.
say it processes or produces red blood cells in the kidney?
It produces,
Okay.
yeah, it produces. I believe it's on the top of the medulla of the kidney, but let me double check on that. So bone marrow is one place to produce your red cells, but also the kidney. Yeah, that's why these patients, they come in anemic and very yellow. They almost glow in these fluorescent light because they are just all the cells, all the toxic stuff being accumulated. You can almost see that on their skin. Questions? If not, now it's 10:30. We'll take the 15-minute break and we'll come back at 10:50.